The COVID-19 pandemic has affected all areas of medicine, including eye banking. Stricter donor selection criteria have reduced the overall donor pool by 40 to 70% in different eye banks globally, including our own. However, the demand for keratoplasty remains the same. So we need to be wiser so that we can double the utilization rate. Most practically, using the same donor tissues for DMEK and DALK. Here we describe a novel BCL interface technique of donor preparation in DMEK so that the anterior part can be used for DALK. We have no financial interest in this video. Conventionally, most surgeons use a stamped DMEK graft for ease of orientation during unscrolling. To make that, we need an S or an F stamp on the DM side during donor preparation, which is done through a 3 mm stromal window. And naturally, after the window is made, the anterior part of the tissue cannot be used for DALK or other surgeries. In the novel technique using BCL interface, we modify some of these steps. The tissue is first placed on a Teflon block with the endothelial side up, and a 9.5 mm partial trephination is done. It is then stained with trypan blue to identify the cut margins. The peripheral DM beyond the trephination is then stripped off. The DM endothelial edge is carefully identified and loosened all 360 degrees with an elevator instrument. Then, using McPherson forceps, the DM graft is gently peeled from the stroma almost entirely, leaving behind a 1 to 1.5 mm hinge. We then move to a second Teflon block where a BCL is placed and refined to 12 mm. Trimming it down to size helps in better air trapping. A 3 mm central or slightly eccentric punch of the BCL is done. The trimmed BCL with central window is again stained with trypan blue for easier identification. This is then placed onto the stripped part of the donor corneal stroma. Very carefully, the stripped DM endothelium is floated back on the BCL surface and the water soaked to prevent it from slipping. The hinged part of the donor graft is then separated, and the entire DM endothelium graft is gently centered on the BCL. The interface fluid is soaked so that the graft sticks to the BCL due to surface tension. Now the BCL supported tissue is flipped over and air is trapped so that it doesn't collapse. The exposed descemex is dried carefully through the 3 mm window, and the S stamp is placed as usual. The BCL and DM complex is flipped back. It is then placed on the second Teflon block with the endothelium side up. And now the final 8 mm trephination is done. The DMEK graft is carefully transferred to the cup of the donor tissue and stained with trypan blue and subsequently washed with BSS. The stamped graft is now ready. It is then transferred to a petri dish containing BSS, ready to be loaded into the injector system. The remaining anterior part of the donor tissue is then kept back in the preservative media, which is now ready for donor preparation in DALK surgery of 8 to 8.5 mm graft. Since the faint 9.5 mm from the initial partial trephination is already there, harvesting up to 9.5 mm DALK graft is possible, and there is no need to do descemex endothelial removal in this case. During the past pandemic-stricken year, We have used this BCL interface technique in about 40 donor tissues, 17 of which were used for DALK. The other cases, the tissue was used for tectonic, large therapeutic grafts as a globe-saving procedure. The key steps for this BCL interface technique in DMEK graft preparation are: complete 360-degree loosening of the DM with a fine elevator-like instrument, peeling of the DM endothelium complex up to 90 to 95%, which is more than what is done conventionally. Sizing of the BCL to 12 mm for better air trapping. Central punching of BCL with a 3 mm trephine. Placement of this windowed BCL between the stroma and then careful flotation of the DM endothelium over it. Good centration of the DM endothelium over the BCL. Soak the interface fluid. Flip the BCL supported tissue, dry the DM surface and give the S-stamp. Final 8 mm trephination. Which is then transferred to the anterior stromal donor tissue cup. And then finally staining with trypan blue and transferring it to a petri dish. Apart from DALK, the remaining tissue can be used for tectonic grafts, large therapeutic keratoplasty, or even as a carrier for a Boston type 1 keratoprosthesis. Thank you for watching.